that the role of the CIO has changed totally. You know, we were software developers and architects, and we could tell you what RAM to use based on its transactional speed. Do you think any of that matters anymore? The answer is no.
Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics. I was the CIO for a 23,000 person health system, and one of the biggest challenges was to remain current on the technology and the trends that were going on myself.
Think of artificial intelligence as a orchestra. Right now, machine learning, deep learning is getting a lot of attention, so I sort of equate that to the string section. And obviously there are many sections to the orchestra, so someday soon, hospitals, healthcare organizations are going to be able to have amazing music.
We are seeing instances of folks popping up, us included, where we're having a primary care physician set up with the dentist in the same office.
I would love to get to the space where eventually we're using voice recognition to do all of our navigation throughout the electronic health record.
When we worked at Microsoft, oftentimes, you'd have crazy deadlines. People would say, look, we're not saving anyone's life here. We can't say that anymore. And we love that. It's like we can save someone's life. We can prevent a complication or a readmission by catching it.
A lot of the feedback people are hearing about former Vice President's remarks is that he was remarkably pragmatic. And then the one that I'm most excited about, he notes that the Medicare Innovation Center, which was created by the Affordable Care Act, has the legal authority to experiment with new models to engage patients for purposes of getting better value care.
Hyper-consumerism driving everything to a digital experience, because if we don't make it easy for patients like ourselves to use healthcare on our smart devices, companies like Apple are starting to do it for us.
I think we're right on the cusp of a huge digital transformation. It'll be interesting to see how CIOs sort of address that. Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. This is episode number 33. Today we discuss the Data Quake, a term that's used to describe the transformation potential of data in healthcare and the emergence of an application ecosystem in healthcare. Plus, we're going to take a look at healthcare data breaches for 2018, give you an update, and have a discussion around that. This podcast is brought to you by Health Lyrics. Health systems are moving to the cloud to gain agility, efficiency, and new capabilities. Work with a trusted partner that has been moving health systems to the cloud since 2010. Visit healthlyrics.com to schedule your free consultation. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics. Before I get to our guests, just a quick update. I want to thank everyone who's participated in our listener drive. We were able to raise $3,000 for Hope Builders, an organization that provides life skills and job training for disadvantaged youth. I've hired their graduates. Their stories are amazing. Thank you for giving us the opportunity to support the next round of students in this great program. Today we're joined by Nassar Nizami, the Chief Information Officer for Thomas Jefferson University and Jefferson Health out of Philadelphia. Good morning, Nassar, and welcome to the show.
Good morning, Bill. Thank you for inviting me. It's a pleasure.
Well, I'm looking forward to our conversation. It should be fun. So tell us a little bit about Jefferson University and Jefferson Health.
Sure. So we are a 14-hospital health system serving patients in Philadelphia and surrounding communities, including Southern Jersey. Thomas Jefferson has been around for 200 years now. We are 30,000 strong, reimagining healthcare education and about $5 billion in revenue. We're an academic medical center with Thomas Jefferson University being our flagship university and hospital. All of our hospitals are teaching hospitals.
Yeah, that's a fairly sizable system. And so just Philadelphia and Southern, or are you Philadelphia and Southern New Jersey?
Yes.
Are you doing a lot of things like telehealth across those? Are you expanding into more retail type locations?
All of the above.
All of the above.
Telehealth is big. Telehealth is big. We are expanding in telehealth, and we are seeing more and more traction in our telehealth technologies, both in our ED, and then folks calling in and opting for a telehealth or a video appointment instead of a physical appointment. We're working with local retail clinics as well. It's a lot going on.
Yeah, I'm looking forward to it. I have a lot of friends, and I grew up just outside of Philly. I have a lot of friends. I have family that lives there, so they're looking forward to hearing you describe what Jefferson's doing in some of these areas. So it's exciting. So let me give people a little bit of your bio. So obviously CIO for Jefferson. Prior to that, you were Vice President of IT at New York Presby. And prior to that, at Yale several IT roles at Yale New Haven Health System, including CISO. So that's why I'm excited. I don't get CISOs on the show all that often, or people with CISO background. So it's good to talk security every now and then. It's such a huge topic for us. And then you have a couple degrees. You have an MBA from Columbia University. Master's in Science in Computer Engineering, and a BS in Electrical Engineering. So I guess what we can surmise from that is that you're either really good at school or very smart.
So I'm a techie. So that's what I'd like to call myself. Yeah.
Yeah. So what's it like living in? Give us an idea of Philadelphia and the area of Philadelphia. I mean, is it a good tech scene? Are you able to hire the kind of people and attract the kind of people you're looking for?
All right. So I think these are two different questions. And remember, I come from New York. So is it a good tech scene? This is an awesome tech scene. So tons of startups. There are a lot of cool things happening within healthcare and outside healthcare. I get to meet folks who are really in startups and mature organizations that they're really in the forefront of innovation. From a metro city point of view, you find everything that you'd expect in any metro city. Now, hiring is a different story. So we have some really talented people, but it's not been easy to hire. It's not very different than what I experienced in New Jersey. I've been only in the area for a year now. I'll be completing my year next month. But it's hiring talent has been a challenge.
Yeah.
And I think that's a story across the board. That's not unique to us, but in metro cities, I think just the competition is so much. We are competing with a number of for-profit and commercial organizations. It just makes it a little bit tough.
Yeah, absolutely. So one of the things we like to do with our guests is to just open the floor, give you a couple minutes to just talk about anything you're excited about or what you're working on today.
All right, so that's a tough question because we are doing a number of cool things, from innovation to XR and VR and expanding EMRs and figuring out unique ways of using FHIR. There is a lot going on our infrastructure team, so it's difficult for me to pick one area. With that said, I would say one of the areas that I'm very excited about is the work our team is doing in data analytics, especially predictive analytics. And I really believe that we have an opportunity to influence patient care in a meaningful way via predictive analytics. I'll share an example with you. We at Jefferson, we have an OPI task force. This is a national issue. Our team developed a scorecard, which we call OPI Provider Scorecard, and the insights from the scorecard led to changes in provider workflow that resulted in a 91% drop in prescribing beyond 3 days. Our team has presented this work at national forums. We recently demonstrated it at the Philadelphia Health Commissioner's Office, who is interested in disseminating it to other systems in the area. And this is just one example. There are a number of other use cases that we have worked on successfully and working on. For instance, we are working on predicting sepsis. And just again, another example. Yep. I'll just finish by saying that there is a lot of buzz around AI, machine learning, and predictive analytics. And I believe, at least in the short run, focus on point solutions will give organizations like ours most value. This is where we are seeing this, and this is where I'm really excited.
Yeah, absolutely. And that's, I mean, that's really exciting that you guys are, and you set up our first story really well in terms of how data can really transform things like the opioid epidemic and really addressing it head on. And, you know, we've been doing things like readmissions for years and those kind of things, but now we're getting very focused on things that are going to impact the community, things that are going to impact quality outcomes. And it's really exciting. The hard thing is there's so many areas to get to really focus in on predictive analytics that it's hard to have enough staff and enough bandwidth to really do all the things that you want to do. I mean, that's been my experience in analytics. You really could quadruple the size of your team and be doing phenomenal things. So, all right. So, you know, on our show, we do 2 segments. In the news, we each pick a story and discuss, and then we do sound bites where I'll ask you a series of questions. You have a hard stop in about 33 minutes, so we'll keep it moving. So my story is CMS just completed their conference on interoperability and Blue Button 2.0, and there was a lot of exciting really vision casting kind of things. Now, we all know that there's challenges in terms of getting the data out and where we're at today, but in terms of really a vision, you really got a very clear picture of where they see things going. So this story is from Healthcare IT News. Healthcare app economy is coming. Get ready for the Data Quake. And I'm going to bounce around to a couple stories. So a Silicon Valley venture capitalist dropped the word. One doesn't hear every day, Data Quake. We're going to look back at 2018, 2019. He says, those were the years of the Data Quake, said John Doerr, Chairman Kleiner Perkins, Caulfield and Byers. Data was required to be interoperable. Innovators came together to move us to an app economy. So they're starting to paint this vision of the data's getting to such a place that we're going to start to see things like like an Apple App Store for health apps. So let me hit a couple of the key things on this. So Administrator Seema Verma urged health insurance companies to follow the center's CMS lead to make claims data more readily available. She says, we're at the beginning of the digital health revolution. We have the ability to take that data and unleash it. She said during the Blue Button conference, we're unleashing the most powerful force in our economy, the consumer. Verma added that CMS is creating a new type of patient profile by making the agency's massive amounts of claims data available to the public via Blue Button 2.0. And she said, we're not stopping there. We're leading by example and calling on all insurers to release data in an API format, Verma said. You'll see through our regulatory process that we're very serious about that. You know, they talk about not only releasing the CMS claims data, they talk about encouraging payers to release their data. More than 600 developers signed up for Blue Button 2.0 to start experimenting. I think that number's up over 700 now. And that which will give them access to, the developers can build integrations across more than 4 years of Medicare Part A, B, D data for 53 million Medicare beneficiaries. And if that wasn't enough, you had Amazon, Google, IBM, Microsoft, Oracle, Salesforce pledge to remove interoperability barriers. So in terms of just visioning, big day for them, just laying out this vision for freeing that healthcare data, putting it in the hands of developers and clinicians to really rethink how we use the data. And so they're putting it out there. So let's just start with, let's riff on this vision a little bit. So does the data have the ability to change healthcare as it has in just about every other industry, or are we going to see some barriers?
Absolutely. First of all, great news, great article. And I think one of the other people quoted in the article, Hemant Taneja, said something about consumerization, you know, and I absolutely agree with that. Yeah. A consumer-like ecosystem. And I think that the shift have been slow. It's been happening for a while. And truly, I think it's a matter of when, not if, right? And there are many reasons to believe that now is the time, okay? And there are many reasons to liberate the data. First is direct patient care. The ability for patients and provider to access relevant data regardless of direct access to EMR, there's a lot of good work being done in the name of interoperability, which needs to continue, all right? And I absolutely believe, to your point, that data in the hands of researchers and developers and entrepreneurs will truly change the way we provide healthcare. There is a ton of data in EMRs and other clinical systems which is not used. Overwhelming majority of it just sits there for legal or compliance or historical reasons. And this is the data that in the hands of entrepreneurs and research community can do wonders. Now, you asked about barriers. Yes, there are barriers. First, we have to think through privacy implication. For instance, companies like Apple are not covered by HIPAA, right? And there is a level of expectation from consumers, patients, about the safety. For the last 20 years, we have told everyone that your patient information is covered by HIPAA and so forth. These third parties don't have those protections, I guess, right? So we have to just think through it. Doesn't mean that it should not be open. I'm all for opening. It's just that we have to think about the implications of making sure that patient data is protected. There are really real technical barriers to interoperability and openness. And as an industry, we have been trying to solve those for many years. There have been many successes. You know, this conference was Blue Button 2.0. There was 1.0. So there are a lot of lessons learned, and there are going to be more lessons learned. I think the time is right. We need some push from our policymakers. We need engagement from organizations like Google and Microsoft who have the resources to make things happen. And I think researchers will do their job. And good things will come, similar to app economy that we saw in last decade.
Yep, absolutely. So, so one of the primary principles of Blue Button 2.0 is to get the patient record in the hands of the consumer. So it completely frees it, gets it on the phone. And once it gets it on the phone, then as you pointed out, there's no HIPAA on security on Apple. And part of the reason for that is Apple's essentially the consumer's giving it to Apple. And, they're not really putting that requirement on Apple yet. I think we'll see that sort of emerge here, given the landscape that's going on. But we put the record in the hands of the patient. Do you think that's going to open up? I don't know. I've talked about this a lot on this show. I've talked about once we get the record in the hands of the patient, that we're going to see all sorts of new paradigms start to emerge. In that the patient's going to be able to decide to sell their data. It's not going to be something that a health system decides to do, or claims data gets sold, and new industries get created. But there's going to be the ability for me, the patient, to go, I want to participate in this cancer study. I want to participate in this heart study, and potentially get compensated for it. Here's $5 for this, or $10 for that. So we'll create a sort of a data economy there. Plus, we'll create all sorts of new, really access changes. As I go from health system to health system, or I move from place to place, or I decide to use telehealth from a different provider, I'm going to be able to provide them my record instead of them having to request the record from another health system. Do you let's start here. Do you think the patient should own the medical record? Do you think we should put it on every phone? You're a former security guy, so you know what that means. And then do you think that's going to enable more or different kinds of, ways of delivering health to that population? And is that going to really impact the health systems today?
So first of all, absolutely, patient owns data. And up until now, they just didn't have a way to access them. And other than, getting a printed copy of their medical record, or in some cases going to a web portal and trying to figure out what's happening. So the ways that we provide our patient data is inefficient and inadequate. And there's certainly not ways where a patient can easily say, hey, physician, this is my record from a hospital, this is my X-ray or lab results and so forth. So that's going to be very powerful. I think absolutely patient owns the data, and we need to make sure that the transfer of data from patient to whoever the patient is seeing, whether it's a hospital or a physician, is very easy, it's very quick, and it happens in a timely fashion. That is an absolute must. I think that what I'm concerned about is the lack of understanding with the security. So, we see in the news what's happening with Facebook and Google and GDPR, especially in Europe, and just the realization by people that their non-health data, their social media data, can be used in ways that nobody imagined, right? And can be mined in ways that nobody can ever imagine. Yep. And I think there's an educational component, first and foremost, to educate the patient that what can they expect once they share their data. Because Apple or Facebook, they are known to share the data with third parties. And I believe that Apple already have in their terms and conditions where they can share the data with third parties. So before a patient knows the data is going to be not only with companies like Apple or Google, but all the ecosystem that they support. And I think first and foremost is an educational thing. The patient has to realize what they're sharing. And secondly, I think you will see some more rules and regulations around them. Probably it'll be a catch-up, like HIPAA was a catch-up. Yeah. But I think that will happen. That's a must. I'm not sure about the monetization piece, because for most companies, the benefit of the data is from scale, the millions of data sets that I think for foreseeable future is still larger organizations will manage. But that does not mean but I still believe that the given data to patient is very powerful. There may be organizations that are interested in a very niche studies. So you mentioned cancer. So if I'm an organization and my interest in lung cancer, I don't need hundreds of thousands perhaps, and contacting a very special population and targeted population could probably help an independent researcher or a company who don't today have the means or have to spend a ton of money to gather that data. So again, what I think is liberation of data is going to be very powerful. There are going to be some issues to both technology, privacy, and security that we'll have to address. But I think we're at a point where even if we don't address the barriers and the issues, I think the liberation of data will happen.
So closing question, given the three key movements, FHIR, the Apple announcement and their partnership with health systems that they're bringing data in, and Blue Button 2.0, which of those three do you think has the biggest impact on bringing this app economy into fruition or bringing it to bear?
Sure. Instead of picking one, I would say is the push from the government, right, on opening up is probably the catalyst. Right? And the interest from organizations like Apple and Google and Amazon, I think, is just going to accelerate that. So all of the above is the short answer, but I think the role of our policymakers probably is going to be most critical in I'm not sure if forcing is the right word, but forcing the opening of data, making sure that data gets open and interoperability actually happens.
Strongly encouraging based on reimbursements and payments. Yes.
You have a better choice of words than I do.
It's interesting. So we're going to transition to the next story, but we're so worried about privacy and security in giving the record to the patient, but we're going to transition to the story, and it's going to look like, hey, we're not doing that great of a job as health systems today in protecting the data. So why don't you set this one up, and then we'll go into it.
Sure. This was an article that was published yesterday's news in Becker's Health. It's an article that is a summary of breaches reported to OCR. So all organizations under HIPAA are supposed to report their breaches of over a certain threshold to OCR, and OCR then makes that information public. And this article was a summary of all the breaches that were reported in the first half of this year. And it stood out because of some interesting trends. First, we have already surpassed the number of records that were breached in 2017, and we still have 5 more months to go in this year. And incidents reported as hacking are on the rise. And if the current trend continue, the number could be 40 to 50% higher than what we saw in 2017. So I think that's an interesting aspect, and it tells us as an industry on where we should be putting our resources in. And this is, I think, supported by some positive aspects. The incident reported as theft or loss have steadied over the last 3 years, and probably because of the requirement to encrypt by many organizations. So as you know, if the laptop or device that is lost or stolen and is encrypted, then it's not a reportable incident. And there are some requirements on encryption and so forth. But I think that over the last 5 or 6 years, 7 years, this requirement or incentive to encrypt data forced organizations or strongly encouraged the organizations to encrypt. And because of that, we are seeing the results of a steadying of incidents there. So now that we see a rise in hacking-related incidents, I think that's an area where we need to focus. And I think there are other areas, the inappropriate disclosure is also studied, but all expected. But the reason I thought that this was interesting is that, this, and you think about this in the context of everything else, hacking this by Russians in the news and so forth. And this just highlights an area which we still are, as an industry, are struggling with.
Yep. So let me give a few more just data points, and then I'm going to ask you. I rarely get a CISO on the show, or someone who used to be. So it's helpful. So 2016, 450 breaches, 27.5 million records. 2017, 477 breaches, 5.6 million records breached. Over one breach a day at this point. 2017, 18, primary cause was hacking, as you pointed out. So that's on the rise. But here's some other numbers which I think are pretty staggering. Between 2009 to 2017, there have been 2,181 healthcare data breaches. Those breaches have resulted in a theft exposure of 176 million health records, which is over 50% of the population in the United States. So over 50% of the people have received those, hey, we'll protect your identity papers. The two causes we talked about, hacking incidents and then insider breaches, is the other primary cause. Let's see, couple more. Hacking IT incidents resulted in the exposure theft of 3 million records, although detailed data is only available on 144 of those breaches. In 2016, 86% of the breaches were attributed to hacking incidents. In 2016, 120 hacking incidents were reported, which resulted in exposure of 23 million records. The severity of hacks, insider threats was therefore far lower in 2017, even though hacking incidents were more numerous. Couple other things I think are insider breaches continue to plague the healthcare industry. Data is available on 143 of those. They actually break it down into two categories: insider wrongdoing, which includes theft and snooping. That's just somebody trying to find Britney Spears' record or whatever. The breakdown was 102 inside errors and 70 cases of insider wrongdoing. 4 incidents were classified as both. So you have, these are two big categories, right? You have you have incidents that are attributed to your employees. You have incidents that are attributed to hackers. And I think the last thing I wanted to point out, so reports of healthcare data breaches in 2017 show that in many cases breaches are not detected until many months after the breach occurred. The average time to discover a breach based on those incidents that they looked at was 308 days. And the average in the prior year was 233 days. And it actually, they say it should be noted that the data was skewed because some breaches that occurred, they didn't detect for more than a decade. So So I'd like to break our conversation down into 3 areas: prevention, detection, and response. So from a prevention standpoint, ransomware is on the rise. What can health systems do to prevent or prepare for these types of hacking attacks?
So I think, to think about prevent, detect, and respond is the right way to think, right? And and I think the best controls are preventative controls. So things never happen, hopefully, right? And I think as an industry, we have made some good progress in the last 6 or 7 years around prevention controls. Most organizations had firewalls for the last 10, 15 years. So that's a given now. There are a new generation of firewalls that are happening that are really good at application level analysis and so forth. That's an area. But I think the biggest bang for buck an organization can probably get from a prevention point of view is probably from a technology. I will talk about this in a technology and then human sense. So two categories. From a technology point of view, in my opinion, is multi-factor authentication. Okay, and it just makes it very difficult for someone who is actively trying to access information. It does not. It's not a cure-all, it's not a silver bullet, but I think that multi-factor authentication has been a challenge in healthcare to implement because of cultural reasons and the need for physicians to get to a patient record immediately and so on and so forth. So there have been reasons that it has not, industry has not adopted it wholeheartedly. Like if, for instance, in banking or other commercial industries, most of them, their workforce has to use two-factor authentication or multi-factor authentication. Secondly, I think in almost now most of the breaches that we see, which are under hacking, or you mentioned ransomware, involve some person doing something that they're not supposed to do. So it could be opening an email or going to a website and installing something, and that cannot be emphasized enough, I think. Because the real protection that you can do is train your workforce at different levels. So many organizations now have dedicated security teams. They are the experts but those people are probably, a handful of people in any, even size, a large organization, they're a handful. But then you have your folks in technology, who I think money well spent is training them on security, to make them your first line of defense, and then population in general, right? So there are technological solutions. I mentioned MFA, I mentioned firewalls, there are data loss prevention solutions. There are many technological solutions that, we can implement, some of which I mentioned, but I think any organization that is interested in securing and proactively protecting to tie the human side with the technology that they're implementing.
Yeah, the weakness is the human. So let's shift gears to detection. So one of the things that changed the way I think about security is one of our vendors came in and said, you need to start designing as if they're already in. Just assume they're already in your network. There's no walls you can put up that can keep them out. I'm like, okay. So that actually transformed how I thought about security and prevention. The other thing was a CIO told me he contracted with one of the firms. It could be our RSA or one of the firms. And what he wanted them to do was to see if he could get physician credentials on the black market. And they were able to, within, I think, 24 to 48 hours, procure about 5 or 6 of their physicians' actual credentials, which worked on their system. So they were able to get into a Citrix environment, get into the medical record, and start moving around. And so detection becomes becomes almost the front line now, because you're assuming that they're in your network, they're tooling around. So you almost have to look at patterns of usage. If that doctor's looking at the wrong record or records that aren't theirs, are we tracking all those things? So from a detection standpoint, what are some things we can do to detect? First of all, a decade to track a breach is kind of amazing. What are some things we can do to find those incidences quicker and sort of move that cycle forward?
Good. So again, I'll talk about technology and people side of it, because I think people are really, again, very important. So there are technologies now. So I mentioned data loss prevention, SIM technologies, so security and incident and event management systems that can log in real time alert. And this is an area. So we spoke about artificial intelligence and machine learning in the context of health care. But this is an area where I'm seeing some really promising technologies in startups that are coming up ways of detecting in very intelligent ways and correlating events and then alerting. So this is an area there are already some advanced technologies available, and we are evaluating some technologies in this area. But SIM is a must. That's a baseline. DLP, I think, is a must. Healthcare, many healthcare organizations, actually, the people part is a challenge. So we can have the technologies, but do we have the people who are going to look and respond and sift through all the false positives? These technologies tend to create a number of false positives. And in some cases, you know, the false positive is many, many times more than real incidents, right? Do we have the manpower, the trained manpower? And I think that we don't have. As healthcare, in particular, as a nation, we don't have enough security professionals. There is a lack of security professionals for everyone. So the pool is too small to begin with. And especially there is an acute need for more security professionals within healthcare. So I think that looking into third parties, partnering with third parties for 24/7 monitoring is at least in the short term, a stopgap solution. I mean, these are folks like Symantec or like Dell or others who have teams of trained professionals who can monitor the system 24/7. Again, it's not a silver bullet. Things can get through without detection, even if you have 24/7 monitoring. But I think in today's days and age, 24/7 monitoring is a must. And if you're a health system that can afford it to build your own security operations center or SOC, fantastic. But I think most healthcare systems, even our size or even larger than us, cannot afford a 24/7 monitoring. Just that the human capital is just not there. So having the right technologies like SIM, like DLP, and having people who can respond to it, internal and then some external power, but is, I think, one way of dealing with a effective detection scheme, a plan.
Yeah, this is one of those areas where you need to have, it takes a village. It's a series of highly trained experts outside of your organization, experts within monitoring. So I couldn't agree more with what you're saying. All right, so we have about 7 minutes to go. 5 quick questions for you. So we're going to transition to the soundbite section. I throw out these questions, actually short answers, mostly because of time at this point. But so Seema Verma, first question. Seema Verma from CMS just announced healthcare as a fax-free zone by 2020. I think most people would hear this and say, oh, that's not a big deal. But from your perspective, how big of a lift do you think it is going to be for health IT to eliminate faxes by 2020?
Look, first of all, a deadline is necessary if we want to get rid of faxes in American medicine, you know. Therefore, I think it's a step in the right direction. It goes hand in hand with overall interoperability initiative that we just discussed about by CMS and ONC. My Health eData is another one. The easier it becomes to exchange data, lesser the need will be for faxing it, right? Fax machines are dying a slow death. Yeah. We see less and less of them, but they're not gone. And to kill it in the next 2 years is going to be a heavy lift. All right. We have made advances in interoperability. There are a lot more to be done, I think. So it's going to be a challenge where interoperability stops to think about other ways to exchange data. For instance, look, it's much easier to find a fax number of a physician office, print and fax, than finding email address and then sending an encrypted email, right? So we are working with a startup that is an electronic fax on our end, but it takes our fax, stores it on a secure web server, and send a page to the recipient with a link and a one-time password. That's a stopgap that we are working with the startup to solution. But look, I wholeheartedly support the initiative, but I think it's going to be a heavy lift.
Yeah, I agree. Second question. So last year, about this time, ransomware really became really prominent. And so from your perspective, how has healthcare really addressed the specific challenge? We talked about security, but the specific challenge of ransomware?
So look, last year was bad because a number of organizations were hit, as you said, right? I mean, especially WannaCry and Patia had huge impact on a number of health systems. And this first year have been quieter. I believe that the threat is not gone. So I have to say that first. I don't think it's gone. It's very much there and can come back anytime. But organizations took some concrete steps. Many organizations took some steps like implementing or enhancing email protection or blocking access to malicious websites, which has helped, right? But again, I think that the common theme here is that the bad guys are targeting people and technology. All right. And I think we need to continue to focus on people-centered approach. In many of the cases where organizations were hit by ransomware, a common theme is a phishing email that went to someone and then someone clicked on that email, and as a result, the computer system or multiple systems got impacted. So again, the assuming that your people are at the first line of defense and a very important line of defense, I think is critical. And that training need there cannot be emphasized enough.
So innovation is a big part of Jefferson Health. Give us an idea of how, because your innovation team is separate, but work closely. So give us an idea of how IT and the innovation team work together at Jefferson.
Great question. Look, at Jefferson, innovation has a special place. It is one of our pillars, I call, along with healthcare and academics. It's that important to us. IT, my team, we all work hand in hand with our innovation teams. At Jefferson, we have 3 innovation tracks. We are an academic institution, and our researchers are often working with innovation and on innovative solutions. We have a group that works on patents, ensuring that our intellectual property is safe and secured, and then they work on ways to bring it to the market. So this is an inside-out innovation that is happening at Jefferson. We also have a group of people working on startups who are aligned with us and are interested in co-development. This is an example of outside in. Lastly, we have a group of very talented developers who are developing solutions in-house based on the needs identified for Jefferson. We work with all of these groups very closely. We have a very collegial relationship. In most cases, we work with them from the very beginning, where it's an idea being developed, or if it's a vendor that we are talking to. End of the day, for most of the innovation that happens, whether it's inside or outside in or is developed, IT are the implementers and the long-term keeper and manager of the system. Overall, the relationship is great, and together we are working on some really cool initiatives.
That's awesome. So you're an academic medical center. Are there specific challenges in health IT for academic medical centers versus a non-academic medical center?
Absolutely. So I've worked in non-academic setting as well, and I can tell you that there are some significant differences. EMCs have a unique culture, different from most type of organizations. So we have healthcare, but we have also academic. Our mission is to improve lives and to reimagine healthcare, and our mission is to further education, right? So, which means we have researchers who are doing cutting-edge research. They have unique requirements of openness, free access to internet resources. For instance, they want to use file-sharing systems without being tied to specific technology prescribed by corporate IT. In most of the organizations, corporate IT is able to say, hey, look, use box.net or Dropbox, and that is it. That's not the case in EMCs. It's just the requirements, because they're working often with many other organizations, and there are needs to collaborate with other systems. They have very intensive computing needs. Our student population is unique and have different needs from healthcare workforce. They want to bring their own devices and expect that it'll work everywhere, rightfully so. Our students are often ahead of IT and challenging us, and early adopters of consumer technologies. So I think that the culture is the biggest difference. There are different needs. But overall, it's a different culture and makes an interesting and challenging environment to work in.
So, so we're almost out of time. So I'll skip the last question and give you an easy one to see if you've made the transition to Philadelphia. So will the Phillies make the playoffs, and will the Eagles be able to repeat as Super Bowl champions?
So I think I'm much more closer to Eagles and Phillies. So I would say that, Eagles have a really good shot. We are very excited. And I was in New York, which is a huge sports town, but the craziness around all the sports in Philadelphia is, I think, unparalleled. I mean, the city is just crazy about sports, and you would know this. You're a native, so I'm rooting for Eagles.
Yeah, it's it is something else when they do win a championship and they have to grease the poles so people don't climb them and all sorts of other stuff.
Absolutely.
Nassar, thanks for coming on the show. Is there a way for people to follow you? Do you publish things on Twitter or anything like that?
Yeah, so I have a Twitter account. It's Nizami, Nizami. So please follow me, and I like and post occasionally. I don't have a huge following like you, but I'm on Twitter, yeah. Or friend me on LinkedIn. I'd love to connect, and if there is anything I can assist or help with, absolutely.
Yeah, it's hard to run a 15, 16 hospital system and be active on Twitter and social media. But awesome. You can follow me at the Patient CIO on Twitter, my writing on the Health Lyrics website. Don't forget to follow the show on Twitter this week in HIT. And check out the website, thisweekinhealthit.com. Catch all the videos on the YouTube channel this week in healthit.com/video. And please come back every Friday for more news, information, and commentary from industry influencers. That's all for now.